morning. I'm Rob Mechanic. I'm Executive Director for the Institute for Accountable Care, and I'm here today with Pippa Shulman. Dr. Pippa Shulman is Medical Director for the Atrius Health Center for Innovation. Pippa is a primary care physician and with a specialty in geriatrics, so it's nice to be here with you today.
Thank you, Rob.
So you've been seeing patients in their homes for a long time before you got started with Hospital at Home. Tell us a little bit about that.
It's true. I'm originally trained as a family physician, and as part of my family medicine training, we had a frail elder house call program. And so I took on patients even in my first year of residency and took care of them in their homes for the entire duration of my residency. And that got me hooked on home care, as it were. And so even at the beginning of my career at Harvard Vanguard and then Atrius, I saw patients in their homes on an episodic basis. We also have primary care at home and nurse practitioner run post-acute care at home. And so sometimes I would make home visits to support patients in that capacity. In addition, I've done hospice care in the home and palliative care in the home. And I've said many times, and I really believe it, you don't really know your patients until you see them in their homes, because you get a visual of their family situation or lack of family situation and all of the social determinants that play into their care. And you understand, how does someone really take their medicines? You understand that when you're sitting at their kitchen table and they're showing you how they do it.
So you're probably the right person then to develop this Hospital at Home program. So give me a brief rundown on what is Hospital at Home?
Hospital at Home's been around a long time, and I can't take credit for inventing it by any stretch of the imagination. It's actually around the world, there are lots of examples of home hospital programs that have been up and running and are caring for thousands of patients. Australia is one example. The NHS is one example. In the United States, we've had a little trouble getting it going, and I think we'll talk about why that is. Yeah. But there are programs all over the country, both in health systems. In the VA does some hospital at home programs, and in integrated payer health system models. And we were really interested about home hospital because at Atrius, we're an independent multi-specialty practice. Right. We don't own hospitals, and we accept risk on over half of our patients. And so our goal is that our patients get the highest quality care in the lowest cost setting of care. And unfortunately, hospitals are the highest cost setting of care in our system right now.
Yeah, okay. And so walk us through kind of when you get started with a hospital at home episode. How do you enroll a patient, and then what happens after that?
Sure. We think somewhere between or around 20% of hospital admissions potentially could be appropriate for home hospitalization. It's not everybody. Hospitals are still going to be really useful for certain groups of patients. But for patients with, acute exacerbation of chronic disease, patients who might be older and be at higher risk for some of the side effects of being in the hospital, like delirium or falls or hospital-acquired infection, some postoperative patients, being able to provide their acute hospital care in their home environment is an ideal option. And so we're really looking for patients where most of what they need is treatment. So we're not bringing MRIs to your living room, but we are bringing infusion and X-ray and ultrasound and nursing care and even home health aides. In our model, patients are admitted from either their homes, so they might have been evaluated in their home care program, from our practice, either primary care, urgent care, or specialty care, or in some cases directly from one of our partner emergency departments. So patients who've been seen, evaluated, are appropriate for the hospital, and they're offered a choice. You can go into the traditional hospital or to home hospital. And patients who elect for the home hospitalization, we meet them in their home. We make sure it's a safe environment to receive care. We deliver any needed DME, durable medical equipment, medications. We'll even provide an aid if someone needs a 24-hour care for the first day or two. They are cared for in that, high intensity acute model for about 3 to 5 days. And then in our model, we actually keep them for another 1 to 3 weeks, which we really call a sort of restorative time to address episode prevention, medication adherence, connect them with social services as required, and really make sure that we're not following the pattern that brick and mortar hospitals do of discharging too soon. So I think home hospital allows you to not be as focused on that length of stay and really make sure that patients are leaving with the same or even improved functional status.
And so it's almost the kind of post-hospital support that would benefit most patients.
Well, I would agree with that.
But most of them don't get that, right?
Indeed, that's true. That's true.
So the people who are providing these services, the physicians, so talk about how physicians are involved. Mm-hmm. What's the role of technology, nursing? What are the different pieces of this and how do they fit together?
Absolutely. So there's a few different ways that people are providing home-based hospital care. Some rely on daily physician visits, with nursing. And we really wanted to expand the care team. So we partnered with a group called Medically Home, and we have nurse practitioners, nurses, therapists, aides, infusion folks going to the patient's home. We also bring a suite of technology in so that we are able to virtually monitor patients, monitor their vital signs, falls detection, things like that. And we provide video capability and support to admission control, where we have physicians and nurse care coordinators available, again, 24 hours a day to be able to respond to patients. So it's really a very intensive in-person model supported by a really robust virtual care system. So it's unique. I think more programs are finding that longer duration of stay is beneficial and are starting to figure out what role technology plays in home hospital programs.
So in essence, it's a virtual hospital call button.
Exactly. So communication is very, very important to us. We make sure that our patients they actually have 3 different ways that they can access us at any given time. We equip them with a PERS, or a personal emergency response device. Yeah. The button, I've fallen and I can't get up. When they push that button, if an ambulance is required, an ambulance can be deployed, but otherwise they're patched into mission control and we address what's happening. We actually give them a special phone. It looks like a phone, but when they pick it up, they don't have to dial. It auto dials right to mission control. And what's even better is they know when that phone rings, it's not a telemarketer or a bill collector, it's their care team. And so we have that. And then we give them a tablet, which does the video link, but also provides them a dashboard of what's going on for the day, what's the schedule, when our medications due, and allows us to communicate a few different ways with patients.
Yeah. How about the patients you've enrolled? Could you tell me about a couple of the patients that you've done a video to of one of your patients?
We have done a video. Our patients are all unique. One great example of a patient was an older woman in her 80s, and she lived independently in an apartment with family support, 2 daughters that lived relatively close by, had multiple chronic medical conditions, and actually had been in the hospital, I believe, 3 times in the previous year. And had an acute worsening of her congestive heart failure on top of some of her other medical conditions. And when she was sick, she, was weak, wasn't getting around as well, even had a little bit of confusion. And so we were able to set up services in her home. We were able to monitor her, give her intravenous furosemide or diuretic medicine to get the excess fluid off. We monitored her heart. We got an echocardiogram or an ultrasound of the heart. We conferred with her cardiologist to make sure the plan of care was a good one. And we were able to transition her to the restorative phase after 5 days. And she was participating in physical therapy. We actually realized that she needed some help with meals, and so got her linked up with Meals on Wheels in her community, and also got some support for her daughters. Her daughters hadn't realized that the patient was having some difficulty organizing medications. And so we created a medication adherence system that worked well for all of them together. And really gave the daughters some resources of where they could get help too. So we say we don't admit just the patient, we actually admit the whole family. And I think that's a good example of where we kind of wrapped around a pretty good system and actually made it even a little bit better when they were discharged. And then we're able to give a warm handoff right to their PCP because it's part of our system. And all of the PCP has access to all of the care that the patient was provided and can see what we've done.
Yeah. So now you've enrolled about 60 patients so far.
We have.
And I think I was wondering sort of about the spread. So this is not something that you've spread fast. And you were telling me something interesting about setting it up. This is not as easy as it looks to set this program up, right?
So 2 things I'll say. One is that, when patient safety is involved, we wanted to make sure we started slow. And so we would admit a patient in the first months and then not admit any more patients as we saw how that system went. And the second piece is that although the clinical care isn't necessarily complicated, getting the supplies, the material goods, and the right personnel to a patient's house in a timely fashion is a challenge. Our current home care environment is set up for a post-acute setting where there's a longer time horizon. It's okay if something arrives tomorrow or next week. When we're talking about patients who are acutely ill and need the hospital, you need something there within hours or even less sometimes, not next week. Our colleagues who have a lot of experience at this in New York City at Mount Sinai always say, you can get a pizza at 2:00 in the morning in New York City, but you can't get oxygen. And the same is true, all over the country. We had to set up an acutely tuned supply chain to be able to make sure that when I order IV antibiotics, that there is a nurse available who can place the appropriate line, that the medications can be delivered, that we have the right equipment that the patient's going to need, and all of that gets to the house in a timely fashion. And that's what made it really important for Atrius to partner with Medically Home to help us with that supply chain so that it is hospital care and it's really safe and of high value for patients.
And you've got, dozens of suppliers that are involved in this supply chain?
We do. We estimate somewhere between 18 and 22 different services or goods are coming into the home. And so you imagine you don't want to just have one supplier for X service or supply. You want to have a backup and a backup to the backup because we cannot fail at delivering patient care. There has to be redundancy. And so when we're opening up this program in Boston, it required something on the order of 56 different contracts. And as we're spreading, we're seeing that. And we want to make sure that we're in a geographic range that's safe. We believe that ultimately, Medically Home is going to shrink down the number of suppliers that's required to 4 or 5. But there's a lot of work going into the goods and services. Whereas I'm worried about the clinical care. And again, that I knew how to do. I didn't know how to get the oxygen there, but I definitely knew how to take care of CHF. So.
Yeah. It seems like once you've got this set up, you have a platform, and there are other things you can do with the platform, not just hospital care at home.
You're right. Once you've established your hospital level services and your safety framework around that and the ability to be in a patient's home at any time of day or night, well, then you start to think about, could we do this for not just medical patients, but actually what about patients post some specific surgeries, elective surgery, for instance, who may have required a few days in the hospital and then a rehabilitation
joint replacement.
Exactly. Joint replacement's a great example. Now, joint replacement is increasingly trying to reduce the facility time. So many of those patients aren't going to SNF anymore or to skilled nursing facilities. But a lot of them are still staying in the hospital. And could we bring some of those patients directly home? We are looking at, are there patients who go in for observation and then go to a SNF stay, a skilled nursing facility stay? Could we take those patients home? Patients who traditionally have a pretty long length of stay, so patients with certain types of infection or with heart failure where You actually get better outcomes if you keep them in the hospital a little longer, but the economics of the length of stay in the hospital make it so we discharge patients to other facilities. Could we take those patients instead, after the first day or so, and actually be able to finish their hospitalization, so to speak, in their homes? So we see a lot of opportunity if we can get the payment right.
Now, one of the other things I wondered about is you're offering an alternative to hospitalization. What do the hospitals think about this?
Depends which hospital you ask. Certainly, there are some hospitals, and I'll speak locally, who are over capacity, who have patients with huge long wait times in the emergency department, which isn't good for patients. The hospitals don't like it. And when we talk to them, they're very interested in having us come and, decant some of that volume off. There are, frankly, other hospitals where that is not a problem. And so their incentives are different because, for a hospital to generate margin, they need to have patients in their beds.
Heads in beds.
Heads in beds, exactly. Now, I think we're seeing an overall, if you look nationwide, an overall shrinkage in the number of beds and, a correction to probably right-size the hospital market. And there's a ways to go on that. So we do have some hospital systems that are interested in partnering with us, but some that we've gone to and they've said, well, this seems like a great idea. Take a walk now. And so we're open to partnering with anybody.
Interesting. Yeah. So what about return on investment? I mean, you're a highly capitated system, but you have to look at sort of what you put in versus what you save. And what have you guys figured out about the financial impact and the quality impact?
Sure. So again, we have small numbers in our pilot, but when we compare our results to the results that are actually in the literature from, again, 20 years of research on hospital at home, we're seeing very similar outcomes. So our readmission rate, and we measure that readmission to an acute care hospital, is lower than it would be for patients coming out of a bricks and mortar hospital. Our costs on average, it's about a third less than it would cost for the same kind of episode of care in a bricks and mortar hospital. We're seeing very high patient satisfaction rates and family satisfaction, which I don't think we measure as well. We do also measure things like falls and infection rate. And again, it's improved over what you would see in the bricks and mortar hospital. And this isn't just us. This is reflected in a long body of research.
So people who are watching and they say, this is a great idea. We want to start to do this. What advice would you give them?
So the two pieces of advice I would give is, one, think about who you want to do this for. There's a temptation to go in and say, let's offer this to everybody. But I think as you're starting out, really thinking about the groups of patients that would benefit most in your environment is important. And the second one is to really think through what we call the supply chain and whether or how you would want to partner to get that done. And really look at what are the capacities that you have and what do you need to either build or buy or partner with someone to get. Being able to deliver timely care is critical. And that's going to be, I think, the hardest part. And it's sometimes the last thing that people look at when they're developing something like this. So don't make those mistakes. Well,
Pippa, you're blazing an exciting path. It looks like a challenging path, but
it's been great. And I've practiced medicine in a lot of different environments, and this has been extremely rewarding and fun. And I feel like I get to build an incredible relationship with these patients and their families, as well as the team taking care of them.